Perfectly hidden depression, or I'm calling it now trauma-based perfectionism, actually, is not a diagnosis. It's very important to make sure I make that point. Perfectly hidden depression was a term that I actually pulled out of the air when I was writing a blog post about some people that I knew and I had worked with, that when they walked in my door, they would have expressly denied that they were depressed. In fact, it would sort of horrify them that someone might think they were depressed. So, perfectly hidden depression is a syndrome. And what a syndrome is a group of behaviors or beliefs that you usually find together. Probably the most well known one is codependency. So I think that perfectly hidden depression is a syndrome made up of 10 traits, and that I have not researched, but my clinical judgment says that this can be found in these people, these traits. And it is a protective camouflage that actually is formed probably early in childhood for most people, because they're growing up in an environment or a culture that, or a family, that doesn't allow them to express and connect with more painful emotions. In fact, it may even belittle or disdain them for doing so. So they decide consciously, perhaps at first, even as a child, that their best survival mode is to begin to disconnect from that pain, to never express it, to create a perfect looking life. So what that can lead to is that what starts out as a conscious process moves into an unconscious process. So often PhD is truly an unconscious phenomenon where someone has created this perfect looking life, but underneath this armor is despair, is even suicidal ideation. And that's what makes it so dangerous. The other thing that I want to, since I know I'm talking to mental health clinicians here, I think it's our job in the mental health field to recognize that this is a form of depression that we are not looking for, that we are not aware of, and that we often just call perfectionism anxiety. And it's so important to realize that actually it could be a barrier, an armor, a camouflage for true despair, depression, even suicidal ideation. When I first started writing about perfectly hidden depression, I got some questions like, are you sure this is really depression? It doesn't look like depression. It doesn't fit the criteria for classic depression, and it does not on the surface. I mean, if you got out your DSM-5, which we all have around the world to look at what are diagnoses, then if you went down the list of criteria, someone with PhD or who identified with PhD would say, no, I've got plenty of energy. No, my thought processes are great. In fact, I'm very successful. No, my appetite's fine. My sleep may be a little off. No, I'm not depressed. I mean, you would literally look at them and they would look at themselves if they were looking for themselves and say, oh, I'm not depressed. I don't know what's wrong, but I'm not depressed. So it's different because it presents differently. It presents um, as someone who knows their gut may be telling them something is wrong, or they realize that they cannot access painful emotions, that they have this shameful inner voice all the time that's criticizing them, and their perfectionism is fueled by fear. That doesn't look like classic depression. Now, there's another term that's around in the literature called high functioning depression. And I believe the difference between perfectly hidden depression and high functioning depression is that most people with high functioning depression, those people that can, they, those people that can get up and go to work and take care of their kids and do all the things that they must do that are the responsibilities, they know they're depressed. They've been to therapy, they're taking medication, they exercise a lot because they know that's what keeps them afloat. They have they understand that they have a history of depression or they have depression, and they are doing something about it, but their life is also going on at the same time. And someone with severe depression really can't do that. I mean, it is so devastating to them that they lack that ability to sometimes even want to brush their teeth. Someone with perfectly hidden depression is never going to look like that. The question shouldn't be, do you feel hopeless? Because someone who identified with perfectly hidden depression would say no. If you felt hopeless, would you tell anyone? The person who identified with perfectly hidden depression would also say, no, I wouldn't. And there would be your window into the life that's behind the curtain, so to speak, the life that this person is leading that is very rigid and compartmentalized and rule bound, and where painful emotions are simply not allowed. So it's very different from classic depression. I've already talked about this some because, again, putting away your DSM-5 and thinking outside of the box as a mental health clinician is very, very important. But one of the things that I think is also very characteristic of anyone with perfectionism of any kind, be it constructive or destructive, and there's a big difference between those two. Constructive perfectionism is more process oriented. It's often fueled by creativity or generosity, or you want to accomplish things, you want to give back, whatever it happens to be, you want to raise your kids well. Whereas destructive perfectionism, and I've said this a few minutes ago, destructive perfectionism is more fueled by fear and shame. However, you are extremely invested in that perfection. And so, in fact, you are so afraid to let mistakes show or to allow vulnerability to show that you 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 cling to that perfectionism. It's sort of like anorexia. When you're trying to treat someone with anorexia, they'll say, my anorexia has been my best friend. Perfectionism is often this person's best friend. It's what they can count on. It's what they have done to achieve and to be successful. And so just the first step is what I call consciousness, with simply helping the person, guiding the person to see, oh, my perfectionism has some loss to it. It has some danger to it. I'm constantly telling myself I should be ashamed and that I need to work harder, and then I've got to hide. And so um, the problem with that perfectionism is that first you have to call it a problem. The second is what I call commitment. So consciousness, commitment is second. People who enter, even if they're coming to therapy and they enter therapy, perfectionists don't want to stay long. They want to start working on the hardest thing first. They don't like to slow down. And so there can be some commitment hurdles. And just imagine taking your armor off, taking that perfectionism off in the middle of your battle. I mean, it's the battle of your life. And so one of the things that I like to, we have a game here in the United States. I don't know if you have it in Italy, but it's called Jenga. And it's a whole bunch of blocks that you very carefully take one out, and the structure must remain solid, must remain stable. If you pull a piece out and the whole thing crumbles, then you lose the game. So working with someone with perfectionism, you have to be very careful about what you ask the person to begin to reconsider or maybe change. The third step is basically cognitive behavioral work, looking at someone's rules, their absolutes, what they must do, should do, and where do those rules come from? And very important to go deeper, what are the beliefs about yourself and about your ability to feel safe and loved that those rules protect you from? So that's the third: consciousness, commitment, uh, confrontation, and then connection. This is about learning how to express emotional pain. I can't tell you the amount of people who have come in my office because of reading about this and who've said, I don't really know what you're talking about. What do you mean, um, expressing my pain? And sometimes we have to get out emotional lists or pie charts to say these are emotions that are very important to feel and to be able to discern. So you're working on that. I also use a trauma timeline where you have the patient go back and begin to talk about the good things that happened to them culturally, familially, environmentally, professionally, personally, and what kind of abuse, neglect, trauma of any kind, whether they bullied or what happened to them, were they hungry? What happened to them that began to shape this need to be perfect? Number five is change. I've been a therapist for 30 years. And I believe that insight is phenomenal. I've watched a lot of people and have had myself aha moments. And those are important moments to have when suddenly you see something differently or you perceive something differently. But you got to put that into practice because that's where you get hope. So you get hope from behavior change. So what I'm saying is in this change process, you have to take all those things that you learned in the first four very interactive stages and begin to apply them and make changes in your behavior. And that is going to lead you to such greater self-acceptance. And it is an honor to be able to help these folks realize that they've been living in a prison, and that prison doesn't have to exist. They can actually find greater self-acceptance, find greater self-compassion. And I'm so excited to come speak to you in Italy about this, and I'm looking forward to it.